You're listening to Psych with Mike, and the most important way to support the show is to find us on YouTube and hit that subscribe button. So no matter how you listen to Psych with Mike, find us on YouTube, smash the subscribe button, and we really appreciate it. Now, here's Psych with Mike. Welcome into the Psych with Mike and Brett Library. This is Dr. Michael Mahan.
And I'm Brett Newcomb.
What is going on today?
You are going to teach me about cluster A personality disorders.
I'm going to teach you.
Oh, yeah.
Maybe even indoctrinate you. Yeah. I was just going to say we did an episode on indoctrination. Maybe I'll be indoctrinating you. But I had this epiphany. I don't know if it was actually an epiphany, but to go over all of the personality disorders, because part of why we do this is to speak to individuals who may be thinking about a career in mental health, may be pursuing a career in mental health. And these are disorders that are oftentimes overlooked because they aren't necessarily robustly covered by insurance. They aren't necessarily taught robustly in graduate school. So we wanted to go over them because we believe that they are still not only viable disorders, but that they are disorders that you are going to come across as a therapist. And so it's important for you to be able to recognize those and at least acknowledge them to yourself, even if you don't make them a diagnosis.
I like when you use the imperial we.
Yeah.
Yeah.
What's that? That's not why you do it?
Right.
So why do you do it?
I think if you're going to be a therapist, you need background training in personality theory. Mm-hmm. You need to have a theory for yourself about how personalities develop, mm-hmm. and a theory for yourself about what you think happens when systems and functionality breaks down. Mm-hmm. When somebody comes to you, they are troubled in mm-hmm. some way. Something is not working in their life. And you have to listen to them, share what their understanding and reality of that is, mm-hmm. and you listen to them for information and for patterns that you can see play out.
Right.
And you compare what you hear and see to what you've studied to say, where does this fit in the map that I have for understanding how people get themselves in trouble or their lives become mm-hmm. somewhat dysfunctional.
So, can I ask you a question?
Certainly.
Okay. Just for full disclosure, there is a personality chapter in the book, which I actually have not written yet, but you have.
Yeah.
So what I would ask you is, when you think in terms, somebody comes into your office as a client, what are you trying to, because I think that most of us think, okay, this person's coming in and they're just this person. I'm going to talk to them about a constellation of symptoms and I'm going to try and help them.
No, I'm going to listen to them.
Okay.
I'm going to try to see them
uh-huh.
and read their nonverbals and understand them accurately. Do that by saying, this is what I'm getting from you as you're telling me these things that you're telling me. Am I getting it accurately? Because I want to see what you have to say and present about yourself before I ever start looking at you and thinking, oh, this is a 30928 problem, or this mm-hmm. is a 7891011 problem. You fit a category. Because if I start to see you as a category or as a label, mm-hmm. then I stop seeing you as a person.
Right.
And that's what Erwin Yalom said over and over again.
Right.
Never see the person
right.
as a diagnosis. See the person as a person. So my job is to see you accurately, reflect that back to you so we're both on the same page in our understanding, and then look for where does it hurt and why mm-hmm. does it hurt? Mm-hmm. And what, if anything, are options for making it not hurt?
Yeah.
If your life is contaminated in some way or disturbed in some way that makes you unhappy, how can we fix that?
I'm just thinking in terms of what the most commonly taught therapy is.
So there are two other factors
solution.
Involved in that, Michael.
Okay.
One is insurance coverage.
Right.
Insurance will decide whether or not to reimburse you for paying me to visit with you based on whether I can give you an appropriately acceptable diagnostic code. That has to mean something to mm-hmm. them. So they use a book called the DSM, and we did a podcast about the DSM mm-hmm. a few weeks back. And they say, okay, any 3 out of 5 of these behaviors in a 2-week period check this box. I mean, we're going to talk about cluster A personality disorders today. There are 3 of them. All 3 of them start with the same sentence.
Mm-hmm.
That's kind of interesting to me. How are they going to be different if they start with the same sentence?
Mm-hmm.
And then what's the degree of difference by which you can tell, if it's A, B, or C?
Mm-hmm.
So the insurance companies get lost in all that, and they compare it to their computer program and the training of their secretaries that they hire to make these decisions. And then if you argue with that and they say, no, we're not going to pay for this, this is not right, and then you write an appeal on behalf of your client saying it is right,
Mm-hmm.
you need to pay for this, then they buck it up to a medical review board, and the medical review board looks at it and says, well, yeah, maybe,
Mm-hmm.
and then they make a decision. So one thing is that. The other thing is trained professionals share a common language.
Mm-hmm.
So if I say to you, Mike, this is somebody who's suffering from anxiety and depression simultaneously. It's a comorbid issue,
Mm-hmm.
and I'm going to label it under the least damaging designator, because if I put this down in paperwork, 20 years from now, somebody will come back and look at your paperwork and go, well, you were treated for depression when you were 17,
Mm-hmm.
so we can't give you a security clearance because you might be suicidal or
Right.
homicide.
Thomas Eagleton was a famous senator from
Yeah.
Missouri who ran into exactly that problem.
Well, he ran into that problem because he was getting shock treatments.
Well, yes.
So, but yes, they said, "Oh my God, we can't vote for a guy. We can't give him the nuclear codes
Right.
if he's got shock treatments going on. His brain may not be stable." So, one is communication among professionals that has a standard transfer of information, and one is insurance companies' pickiness over whether or not they'll reimburse and spend, because they don't insure you to take care of you. They insure you to make money for themselves.
Sure.
So then the other one is, how am I going to help you?
Mm-hmm.
If you and I talk to each other about whatever's going on in your life, is that remotely possible to help your quality of life?
Mm-hmm.
So I don't get caught up in diagnosis per se.
Right.
And all of these distinctions that you're talking about in the cluster A, cluster B, cluster C disorders are interesting to me conceptually.
Mm-hmm.
And I want to know to fit them into my pattern of basic information, but not for me in terms of looking at somebody on a bus and saying, "Oh, that guy's a cluster A right there, boy. He's schizotypal. Look at that."
Yeah.
I don't do that. I would encourage you not to do that. I
But-
don't think that's appropriate.
But you do believe personality is a thing.
Yeah.
Okay, so the most commonly taught, most commonly encouraged for use theory therapy in psychology today is solution focused, brief intervention therapy.
Yeah. Well, again, that's
Because the insurance
driven.
companies,
Yeah.
because the insurance companies love it, and this isn't a treaty on solution focused. We may do that at some point, but that isn't for today. But so in solution focused therapy, you're told, come in, listen to what the client's initial complaint is, and try and solve the problem cooperatively
Right.
with them, and do that in 4 or 5 sessions.
Yeah. It's like you come in and say, I have a phobia for spiders. I just have these panic attacks whenever I encounter a spider. If I suddenly encounter a spider, I mean, I wet my pants and I scream and yell and I hyperventilate and blah, 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 blah. And I'm like, well, we have a treatment protocol for that. It's successful 90% of the time, and we can do it in 3 weeks' time.
Yeah.
And you say, really? After all these years being afraid of spiders, what can I do? I reach down my drawer and I get a spider.
And grab
I
a spider and throw it on you.
Yeah.
That's called
And
flooding.
Die or heal.
Yeah. So, but my original question then would be, when that person comes into your office and you are talking to them, what are you looking for to inform you about this person's personality?
Their description of their experience of reality and their description of how that is not how they want it to be. Mm-hmm. So if you come in and say, I'm having panic attacks about spiders, what I've learned educationally, the background theories and all that, is that you probably have multiple phobias that you may not even have discovered yet because you're focused on spiders. And that a technique that helps with that very often, but not always, is what we call systematic desensitization. So if I can get you to breathe and physically relax by breathing, and then ask you to think about seeing a spider. Just think about seeing a spider. And you start to accelerate again. And I get you to breathe and relax. And I teach you that you can have control over your body and your body's response to the idea of spiders. So we gradually increase the exposure to spiders. Can you look at a picture of a spider? Can you have a rubber spider? What can we do? Not so that you just love spiders and want to adopt them,
Right.
But so that you don't have panic attacks
So you don't have
anymore
panic
when you encounter a spider. We can work on that, and we can make it better if that's all it is.
But I liked what you said about listening to the client and their description of their reality and how that is different than what they would like. I think that's really important
That's
for
what they're
people to
paying me
hear.
for.
Yeah. Yeah. So,
I mean, I'm not going to react to, I'm not going to get emotional contagion. If you start to cry and hyperventilate, I'm not going to cry and hyperventilate. I mean, a therapist can't be afraid of the elephant in the room. I have to be able to say, so what's going on here? Why is this happening? Why are you behaving this way? Where's that coming from? Even if it's awkward or embarrassing. Especially if it's awkward or embarrassing. I can't be afraid to say, who farted? You know, we're all sitting around acting like we didn't know it happened, but we all know it happened.
right.
And that's a problem in the family. If somebody does that, whatever you want to describe that behavior, label it as. So then I have to be able to say, what's going on? You know, I had a good friend that I loved dearly, and she always crunched her ice. She chewed her ice with her mouth open. Drove me nuts. I loved her. I liked to be around her. I liked to be with her. She was a dear friend. But I couldn't stand when we'd have dinner or she'd have a drink or something, crunch that ice with her mouth open. Now, as a friend, not my job to fix that or intervene with that. But if she comes in as a client and says, my boyfriend just broke up with me because I crunched ice, or these people made fun of me and laughed at me and hurt my feelings, then I want to say, so what is it about crunching ice that you are not able or willing to change? What if that's really a problem? I had an 8th grade boy that I worked with for a number of time, for a period of time. He was a snot sucker. He constantly had, I don't know if he had problems with breathing. We sent him to a doctor to find out about that, an ear, nose, and throat guy. But, I mean, his nose was always impacted, and he was always making this loud sucking noise and then swallowing it. And people were getting grossed out. The kids in class would complain about it. The teachers would complain about it. His parents would complain about it. He kept doing it. And he was like, well, that's just the way I am. And I said, okay, that's the way you are. Then this is always going to be the way people react to you.
If you do the same thing over and over again.
I believe that you can change that if it's important enough to you. And I believe we can work on strategies for doing that. And you want to do that? Or do you want people to still reject you?
So would you say that personality is a constellation of behaviors that are normative for that individual? Is that fair? What I mean, would you?
Probably, yeah, I'm comfortable with that.
Okay. So then if we think about the personality disorders, the cluster A, cluster B, cluster C personality disorders are divided in the following categories. So cluster A is odd, eccentric, cluster B is dramatic, erratic, and cluster C is anxious and inhibited. So we've talked a lot about borderline personality. We've talked about narcissistic personality. We will eventually talk about antisocial personality. Those are cluster B. So those are the dramatic, erratic kind of, erratic kind of presentations of who you are as a person. And then the ones that we're talking about today are odd and eccentric. And when you said that all the cluster A disorders start with the same sentence,
let's read that.
Yeah.
Paranoid personality disorder is the first one. People with this disorder are often cold, distant, and unable to form close interpersonal relationships. Schizoid personality disorder. People with this disorder are often cold, distant, introverted, and have an intense fear of intimacy and closeness. C, schizotypal personality disorder. Similar to those with schizoid personality disorder, people with this disorder are often cold, distant, introverted, and have an intense fear of intimacy. It's almost the same descriptor for all three of them.
Right.
So how do you make distinctions accurately?
So the personality type is that these individuals are cold and distant. So I would say that is clearly
Cluster A,
personality type.
Yeah.
So whenever you see that kind of, and again, we don't encourage people to make diagnoses. Certainly if you aren't trained to do that, you shouldn't do that. But to just look at people on the bus and say, oh, this person is X. But when you're a clinician...
Asshole is not a clinical term.
Well, it is between therapists. But if you are a therapist and you are seeing clients as your job, as your profession, then it is important for you to be able to identify these kinds of different personality characteristics because they are important.
Yes.
Yeah. Okay, so they all start with the same sentence. So how do you differentiate them?
Well, I think you start first by identifying, if you're trying to, a category. They're one of these three. So then you look more deeply in the literature and identifying criteria to say how is A different from B, different from C, and which of these. And again, when you talk about personality disorders, you're talking about pervasive ways of being, not situational reaction. So if I am in my home alone and I get startled because somebody's in the house I didn't know was there and I have a reaction, that's a situational reaction.
Right.
That's not my normal global personality and way of interacting with
So
people.
number one,
How pervasive and consistent
it has to
is
be a global presentation.
Right.
You can't just have one time.
You're going to do it at work, you're going to do it at play,
Yeah.
you're going to do it within the family, you're going to do it with strangers. You're going to be that way.
So I would define the difference. So first off, I agree 100% with you that this has to be global. If a person just does it in one context or even in a regular situation, like in when he's playing golf, he does X, then that's not a global presentation. It has to happen everywhere, all the time. If somebody is cold and distant all the time, that may lead you to believe that they have a cluster A personality disorder. But the difference to me is in the thinking. So paranoid thinking is people are out to get me. Just because you think they're out to get you doesn't mean they're not. But
Right.
most people aren't overly obsessed with the idea that people are out or something is out to get them. So that's the distinctive thinking pattern in the paranoid personality disorder. In the schizoid personality disorder, these individuals are oftentimes consumed by their own internal environment. So they're caught up in their own daydreams, in their own thinking. They may actually not be they may lose functionality in certain situations because they get caught up in that kind of internal thinking process. And then with the schizotypal, you have that kind of consumption with that internal thinking process, but the thinking is disordered and somehow is disjointed and erratic, odd, and oftentimes presents like schizophrenia, but not as severe.
So when you say things like their thinking is disordered,
Yeah.
what the hell does that mean?
Well, for therapists, hopefully they know what that means. But for a layperson, what it means is that when you have a conversation with them, that the conclusions that they're drawing from their experience in the world is different than what you would expect from a neurotypical individual, right?
No, I mean, maybe. I don't know. Give me an example. Some client comes in and says, on the bus here today, this older man looked at me and said, "Oh, I really like your dress. That looks really pretty on you." And I knew right away he wanted to have sex with me. Is that what it meant?
No.
Is that what he was saying?
No.
And is that a common response that this woman has to men offering compliments or looking at her and smiling?
No.
So
Yeah.
where's the disordered thinking? Am I assuming that that's disordered thinking, or am I assuming that old pervert was on the bus? My gosh, we should call the bus company.
Well, so disordered thinking would be, I saw a guy on the bus and he commented on my dress,
Yeah.
and so therefore he must work for a spy agency and he's trying to get information from me, and I think he infiltrated my phone.
That's why I have aluminum foil under my hat.
Yeah.
Right.
That's disordered
Keep the
thinking.
aliens from
Yeah,
me.
yeah.
All right.
So, and you know, all of this obviously happens on a spectrum, just like everything happens on a spectrum. But when we're talking about disordered thinking, we're talking about that in a way that is observable or obvious enough that you would say this is not neurotypical. This person is deriving conclusions. They may not be psychotic, right? So psychotic is you're living in a complete fantasy where now you may be psychotic, but this person may not be psychotic, or they may be.
So I was watching a show before I came out to your house
Okay.
this morning. My wife and I were watching a show called Chopped. on television.
Is
It's a cooking show.
okay.
And they have contestants, chefs from different areas who are competing, trying to produce from a surprise basket of goodies the best meal they can. And one of the guys on Chopped was a chef for a religious retreat location.
Okay.
And he says, as he's opening his basket, I always ask God what I should fix with the ingredients in front of me. And God tells me, make a soup. So I'm going to make a soup. How do I understand that?
Well, I think that
First
goes
of all,
back.
is God a chef?
Is God?
Could he be?
I assume if he's all powerful, he can be whatever he wants to be.
Aha. So
But-
there are presumptions there.
Well, yes, and
Or it's
so,
disordered thinking.
or we go back to the conversation we had on indoctrination, and this person just believes his religious convictions uncritically, and he applies that in
And he
all
believes
aspects
God
of his
talks
life.
to him and says, make a soup. Okay.
And we can.
So you reality test it? Did anybody else hear God say that?
Well, obviously, well, not obviously, but most religious theologians, I think, would say that probably that's a very personal process and that other people don't hear the voice of God out loud.
No, I don't think most religious theologians would say that.
You don't?
No, they would say God talks to me, he doesn't talk to you.
No. Well,
Because
that's.
God told me he wasn't talking to you.
Yeah.
Like that Ray Stevens song, would Jesus admit he'd been talking to all those preachers and claim they've been talking to him?
Right. Well, that's a horse of a different color. But
Oh, okay.
Yeah.
It's not a disordered thinking. I'm messing with you.
Yeah.
The thing that really bothers
no,
me.
but I'm trying to hear your question.
So if I hear that and a
think
client's
about it.
saying that, seriously looking at me and saying,
Right.
God told me fix a soup, how do I understand that as the way it impacts their life and the way they live their life? Does that create problems for them? Does that create solutions
I think
for
that's
them?
exactly it. I think that's exactly
Hello.
it. Is does it create a problem or does it not create a problem? If you have that belief, but that belief is consistent with your personality and it works for you in the world,
If you're happy and everybody's happy with you, then God bless you. Yeah, make soup. Be the soup Nazi.
yeah. So it may not be neurotypical, and so in that way it may be disordered, but
Neurotypical.
that's
We all think that way.
that's the new slang
I
for
know.
normal.
Well, these things are different. When I first started studying this stuff, there were 10 of these. Now there are 3. Because they keep broadening the cluster and changing the terminology. One of these is hysterical personality disorder. I remember learning about hysterical personality disorder, and then right next to it was one called histrionic personality disorder. Now they've subsumed that into a larger category.
Yeah.
So
And that's a cluster B. That's a dramatic erratic. Yeah. Yeah.
is there a cluster F?
No. For
Should be.
what's that stand for?
Falderall.
I think we all know what that stands for. But how often have you used cluster A diagnoses in your practice?
I would say I've never used them unless they had been assigned by someone with a
else.
more elaborate degree than I had. So if a medical doctor, a psychiatrist had said, this is what you're dealing with, then the insurance companies are always going to believe that over what I have to say. So,
And I think that if anybody uses them in their clinical practice, they're most likely to use paranoid personality disorder because that's one that is
I would also suggest
acceptable.
they're most likely to use them in a hospital setting.
Oh, for sure. For medication purposes.
Well, just for warehousing purposes,
Yeah.
too. I mean, they're not going to put you in a mental hospital unless they think it's pretty serious
Yeah.
and that you need that protection
Yeah.
for yourself.
Yeah. So I've used personality or paranoid personality disorder a handful of times. I've used schizoid personality twice. I'd never have diagnosed anybody as schizotypal. But I don't know if that's because I've never seen anybody who's had that, or if I think that is a severity of presentation that's unlikely to present.
Well, then you go back to DSM-3, and
Yeah.
it will tell you percentages in the population, male and female,
Right.
with this category. So what it's going to tell you is you're highly unlikely to have one.
And
more than one.
And if you're schizotypal, then you're probably going to be severe enough that you may not just walk into a counselor's office, or if you do walk into a counselor's office, you may
have
end up in a
handcuffs.
hospital. Yeah.
I'll just be Tipple.
Okay.
Yeah.
Not the schizo.
Yeah.
So hopefully that conversation is helpful for people. I really enjoyed it. Again, this is one of those conversations that we may not come to conclusions about, but I find to be intellectually fascinating. If you have any questions that you would like us to talk about, we would love to hear from you. You can reach us through the email at psychwithmike.com, or you can go on the YouTubes and leave a comment on one of our presentations. And you should always go to YouTube and subscribe, because that is super beneficial for the show. And the music that appears in Psych with Mike and Brett is written and performed by Mr. Benjamin DeClue. And as always, if it's Friday, it's Psych with Mike and Brett.